Ah,
Welcome back to the deep dive. We are jumping straight into a really crucial clinical topic today, the foundational concepts of infection care.
yeah, we've basically synthesized a whole lot of material here, everything from the underlying pathophysiology right through to prevention protocols.
The idea is to give you that, ultimate shortcut to readiness.
Right. Our mission really is to provide you with the essential blueprint, how to recognize, prevent, and manage infections effectively.
Okay, so before we get into the nitty-gritty protocols, let's lay the groundwork. What exactly is an infection?
Okay, simply put, an infection is the invasion and multiplication of harmful pathogens, microorganisms, that then cause disease or illness.
And these pathogens, they vary in strength, right? That's virulence.
Exactly. Virulence defines how easily a pathogen can cause disease and how severe that disease is likely to be. Some are just much more aggressive than others.
Got it. And clinically, it's super important to know the difference between an active infection and something called colonization. Absolutely vital. Colonization means the microbes are there. They might even be potentially harmful ones, but they aren't actually causing symptoms. They're often just part of the normal flora or kept in check by it.
So infection is the main concept we're tackling.
It is, but you can't really think about it alone. It's always tied up with other key concepts like immunity, definitely inflammation, and maintaining good tissue integrity. They all influence each other.
Okay, that makes sense. So zooming out a bit, the big picture framework is the chain of infection.
Right. And for an infection to actually spread, you need three things to line up. First, a reservoir that's the source of the infectious agent.
Like where the germs live.
Pretty much. Second, you need a susceptible host, someone who can get infected,
Yeah.
and they need a portal of entry, like a way in.
And third,
Third is the route of transmission. How does the pathogen actually get from the reservoir to the host?
okay, let's break those down. What counts as a reservoir?
Well, it can be almost anything. Animate sources, like people, even people without symptoms, or animals,
Mm-hmm.
or inanimate things. Think soil, contaminated water, medical equipment,
Even our phones, probably.
definitely mobile devices. And the source material also flags inanimate environmental factors like particulate matter exposure or PME.
PME, what does that cover?
That's things like inhaling mold spores, dust, certain toxic chemicals. It's often linked to a higher risk of respiratory infections.
Okay, so that's the source. Now, let's focus on the susceptible host. That seems like where we can really intervene clinically.
It is. The host's defenses, largely driven by their immune system, are the main barrier. But lots of things can weaken those defenses.
What are the big risk factors the source material points out? Maybe like in table 21.1, what does that highlight?
Well, the table really points to anything that undermines immunity. So congenital immune issues people are born with, or acquired ones like HIV, even just altering the normal gut flora with antibiotics can make someone more susceptible.
Makes sense. What else?
Malnutrition is a big one. And then, very commonly, medical interventions themselves. Things like invasive therapy, IVs, catheters, chemotherapy, or major surgery. They all increase risk.
And the source material seems to put a special focus on older adults. There's a patient-centered care box about them, right? Why are they particularly vulnerable?
Yeah, age itself brings a lot of changes that increase risk. Their antibody production tends to decrease. Their fever response might be blunted or absent, which can mask infection.
So they might be quite sick, but not spike a high temperature.
Exactly. Plus, their skin thins, it becomes less elastic. Blood supply might not be as good. This affects the barrier function and slows healing. You add that to common functional issues like being less mobile, maybe some incontinence or chronic conditions like diabetes. It really stacks up.
That increased vulnerability really highlights the importance of those portals of entry you mentioned. How do pathogens typically get in?
Common routes are the respiratory tract, breathing things in, the GI tract, ingestion, and the genitourinary tract.
That makes me think of hospital-acquired infections like CAUTIs.
Definitely. Catheter-associated urinary tract infections are a huge issue, directly linked to that portal of entry. Then there's the skin and mucous membranes. If that barrier is broken, trauma, surgery, even just fragile skin, it's an open door.
And direct bloodstream access.
Yes, things like central venous catheters or CVCs, if they get colonized, pathogens have a highway straight into the systemic circulation. Even biting insects can do this.
So if you connect the dots, impaired tissue integrity from skin breakdown or those invasive devices, that directly links to higher infection risk. Feels like a key nursing priority.
Absolutely. It's about protecting that susceptible host, which leads us right into prevention strategies based on how things are transmitted. The PDC lays out three main methods.
Okay, what's the most common way infections spread in healthcare?
That would be contact transmission. It can be direct, literally person-to-person physical touch.
Like shaking hands.
Right. Or indirect touching a contaminated object, what we call a fomite. Think about using a blood pressure cuff on one patient, then another without cleaning it. Or a shared tablet.
Okay, so contact is number one. What's next?
Next is droplet transmission. This involves larger particles expelled when someone coughs, sneezes, even talks. They don't travel very far, usually about 3 to 6 feet.
Like the flu.
Exactly. Influenza, pertussis. That's why social distancing, keeping at least 6 feet apart, was such a focus for COVID-19, which also spreads via droplets.
And the third route.
That's airborne transmission. These are tiny particles, much smaller than droplets, droplet nuclei, or even dust particles carrying pathogens. They can stay suspended in the air for a long time and travel further.
And these are the really serious ones to contain, right? Like TB?
Precisely. Tuberculosis, varicella zoster, chickenpox shingles. These require specific airborne precautions because they're so easily spread through the air.
So understanding those routes helps us choose the right prevention. What's the baseline?
The baseline for everyone is standard precautions. You use these for all patients, regardless of their diagnosis. The core principle is simple. Treat all body fluids, secretions, excretions, except sweat, as potentially infectious. And that means using PPE, appropriate PPE, gloves, gowns, face protection like masks and shields, and sometimes respirators, depending on the anticipated exposure.
Yeah.
But if you had to pick the single most important prevention action, what is it? The action alert in the text really emphasizes this. It's got to be hand hygiene. The sources are absolutely clear. The number one way infections spread, especially in healthcare, is on the hands of healthcare workers, so washing hands or using hand sanitizer.
Both are critical, but you need to know when to use which. Soap and water are essential if your hands are visibly dirty, sticky, or contaminated with blood or body fluids. Critically, you must use soap and water if you're dealing with spore-forming organisms, like C. difficile.
Because the alcohol rubs don't kill spores. Exactly. Alcohol-based hand rubs, or ABHRs, are great for routine decontamination when hands aren't visibly soiled, but they are not effective against spores like C. diff. And the most effective strategy overall, combining good hand hygiene with wearing gloves appropriately.
Okay, so standard precautions are the foundation. What about when we know or suspect a specific type of transmission? That's where transmission-based precautions come in, right? Like Table 21.4 describes.
Correct. These are in addition to standard precautions. Let's start with airborne precautions.
For things like TB, what's required?
You need a special room, an airborne infection isolation room, or AIR. These have negative airflow, meaning air is pulled into the room and filtered before being exhausted outside, preventing pathogens from escaping into the hallway.
And what about protection for the staff going in?
Staff need respiratory protection, typically an N95 respirator, but the source material notes that a PAPR, a powered air purifying respirator, is considered even more effective for maximum protection.
Okay. What about droplet precautions? For flu, maybe?
Simpler. A standard surgical mask is required for anyone entering the room, and maintaining that distance at least 3 feet, ideally more like 6.
And finally, contact precautions.
For contact, you need to put on a gown and gloves before entering the room. This is used for patients known or suspected to be infected or colonized with easily transmissible pathogens, especially multi-drug-resistant organisms, or MDROs.
Like MRSA or VRE, exactly. And also for infections like C. difficile. Which actually brings us neatly into the next big topic, the challenge of antimicrobial resistance.
Yeah. AMR and these MDROs, they're a huge problem. What's something relatively new that's making these infections even harder to treat?
Well, one major discovery complicating things is biofilms. Imagine this complex community of microbes sticking together, and they create this kind of slimy, protective gel coating around themselves.
Where do these form?
Often on medical devices, think catheters, prosthetic joints, implants. They can also form in chronic wounds. This biofilm acts like a shield.
A shield against antibiotics. Precisely. The antibiotics often just can't penetrate that slimy layer to get to the bacteria hidden inside. It makes treatment incredibly difficult.
Okay, let's talk about specific MDROs. Who are the main culprits?
Well, probably the most well-known is MRSA methicillin-resistant Staphylococcus aureus. Staph aureus is actually a common bacterium, often found on the skin.
But when it gets resistant and goes systemic, it's bad news.
Very bad news. It resists standard penicillin-based antibiotics, and we see both hospital-acquired HAMRSA, and community-acquired CAMRSA strains, which really underscores that basic hygiene, hand washing, not sharing personal items is key for prevention everywhere.
Okay, who else is on the list?
VRE, vancomycin-resistant enterococcus. These are bacteria normally found in the gut. The big challenge with VRE is their environmental hardiness. They can survive on surfaces like bed rails or toilets for days, even weeks.
Wow, that makes cleaning crucial. Extremely. And then there's a group that causes a lot of concern, especially in critical care, CRE.
Carbapenem-resistant enterobacteriaceae. This family includes bugs like resistant Klebsiella and E. coli. Carbapenems are powerful, broad-spectrum antibiotics, so when bacteria become resistant to them, treatment options get very limited. These often affect very sick, immunocompromised patients.
Is there anything specific recommended for CRE prevention?
Yeah, the CDC actually recommends chlorhexidine bathing, using antiseptic wipes daily for patients in high-risk settings to try and reduce colonization and prevent CRE infections.
We absolutely have to talk about Clostridium difficile, or CDI. It's often linked to antibiotic use itself, right?
It is. It's kind of an unintended consequence. Broad-spectrum antibiotics wipe out not just the bad bacteria, but also the good protective bacteria in your gut, the normal flora.
And C. diff seizes the opportunity.
Exactly. With the competition gone, C. difficile overgrows and starts producing toxins. These toxins damage the bowel lining, causing that characteristic, often severe, watery diarrhea. It can be debilitating, even fatal, especially for older adults.
So how do we manage it? When do you suspect CDI?
The main clue is diarrhea, typically defined as 3 or more liquid stools within a 24-hour period, especially if the patient has been on antibiotics. Diagnosis is usually confirmed with a lab test like a GIP-PCR on a stool sample.
And treatment involves specific antibiotics like metronidazole or vancomycin. But what about the environmental aspect? We mentioned spores earlier.
Right, huge safety concern. Because C. diff forms spores, those alcohol hand rubs are useless against it. You need soap and water for hand hygiene. And for cleaning the room, you absolutely must use a sporicidal disinfectant. Regular cleaners won't cut it. Plus, strict contact precautions are mandatory.
And what about those really persistent, recurrent cases of CDI? There's a pretty unique therapy now, isn't there?
Yes, fecal microbiota transplantation, or FMT. It sounds unusual, but it's actually a recently approved and often very effective therapy for recurrent CDI.
How does it work?
Essentially, you take stool from a healthy donor, process it, and introduce that healthy collection of normal gut bacteria, the microbiota, into the patient's lower GI tract, usually via colonoscopy. The goal is to restore a healthy gut environment that can keep C. diff in check.
Fascinating. Are there risks?
There are. We need to be aware of ongoing safety monitoring, particularly regarding the potential risk of transmitting other MDROs if the donor stool isn't screened properly.
Okay, let's shift gears to putting this all into action clinically. Assessment and diagnostics. When you first encounter a patient and suspect infection, what history clues should raise a red flag?
Well, age is always a factor, as we discussed. History of chronic diseases, especially things like diabetes that affect immunity and circulation, lifestyle factors like tobacco or alcohol use, any use of immunosuppressive drugs, steroids are a common one.
Recent healthcare exposure.
Definitely. Any recent hospital stay or residence in a nursing home, history of invasive procedures, 5Es, catheters, surgeries, and don't forget travel history. Where have they been? Could they have been exposed to something unusual?
And that ties into the PME idea again.
Exactly. Using a tool like the iPrepare mnemonic helps you remember to ask about potential particulate matter exposure, occupation, hobbies, home environment, things that might increase risk for certain infections.
Okay, so that's the history. What about the physical exam? How do we spot local versus systemic infection? Local infection gives you those classic signs right at the site. Pain, swelling, heat, redness, maybe pus or drainage. But if you see that redness spreading outwards or red streaks leading away from the site, lymphangitis or inflammation of a vein, phlebitis, that's a sign it might be becoming systemic. And the signs of a systemic infection.
Fever is the big one, usually defined as over 101 Fahrenheit or 38.3 Celsius. But remember, in older adults, even a lower temperature, say 99 Fahrenheit or 37.2 Celsius, can be significant. Also, chills, generalized malaise, just feeling unwell, and often tachycardia, a fast heart rate, partly due to the inflammation and maybe dehydration.
We often focus heavily on the physical signs, but what about the psychosocial impact on the patient?
It's really important not to overlook that. Patients can feel incredibly anxious, especially if diagnosis is delayed. Fatigue from the illness itself can be profound. And if it's a transmissible disease, particularly one with social stigma, there can be a lot of stress, guilt, and potential for social isolation. We need to be sensitive to that.
Absolutely. So after the history and physical, we turn to labs. What are the key diagnostic tests?
The definitive test is usually a culture and sensitivity, or CNS. The culture grows the organism from a sample like blood, urine, sputum, wound drainage to identify exactly what pathogen is causing the trouble.
And the sensitivity part.
That tells you which antibiotics will actually work against that specific bug, which drugs will inhibit its growth or kill it. Results usually take, 24 to 72 hours.
And there's a crucial timing point here, right? About starting treatment. Yes, absolutely critical safety point. You must collect the specimen for culture before starting any antimicrobial therapy. If you give antibiotics first, it can mess up the culture results, making it harder to identify the pathogen and choose the right treatment. Okay, CNS is key. What about the white blood cell count?
The WBC count is a standard indicator. Normal is typically around 5,000 to 10,000 per cubic millimeter. In most bacterial infections, you'll see that total count go up, sometimes way up.
And the differential, what's the shift to the left?
The differential breaks down the different types of white blood cells. A shift to the left refers specifically to an increase in the percentage of immature neutrophils, called bands. It means the bone marrow is pumping out new white cells so fast to fight the infection that more immature ones are being released into circulation. It's a classic sign of an acute bacterial infection.
Got it. One more lab, the ESR.
All right, the erythrocyte sedimentation rate, or ESR. It measures how quickly red blood cells settle in a tube of blood. It's a nonspecific marker of inflammation. An elevated ESR, usually over 20 millimeters per hour, suggests inflammation or infection somewhere in the body. It's often elevated in more chronic infectious processes like osteomyelitis, bone infection.
Okay, great overview of diagnostics. Now, for our final segment, let's talk collaborative management. What's the immediate priority when someone has an infection?
The priority collaborative problem is often identified as fever because it's such a common and significant systemic response to the immune system fighting the pathogen.
So the goal of our interventions is twofold.
Exactly. 1, eliminate the underlying cause, destroy the pathogen. 2, manage the symptoms, like the fever itself.
Let's start with destroying the pathogen. That means antimicrobial therapy. What makes it effective? Well, for antimicrobial therapy to work properly, you need 4 things. First, the right drug for the specific pathogen, based ideally on that CNS result. Second, a sufficient dosage. Third, the proper administration, route 4V, oral, etc. And fourth, a sufficient duration of therapy. That last one is so important, isn't it? Finishing the whole course, absolutely critical. We cannot stress enough. Patients must complete the entire prescribed course of antibiotics, even if they start feeling better. Stopping early is a major driver of antibiotic resistance. Can you give a quick example of how different antibiotics work, like penicillins versus others?
Sure. Different classes attack bacteria in different ways. Penicillins, for example, typically work by inhibiting the bacteria's ability to build their cell walls, causing them to break down. Others, like erythromycin, might work by interfering with bacterial protein synthesis, basically stopping them from reproducing. Understanding these mechanisms helps explain why resistance develops and why different drugs are needed for different bugs.
And a huge safety alert when giving any antimicrobial.
Allergies. Always, always, always check for drug allergies before administering any antimicrobial. Anaphylaxis is a potential life-threatening reaction.
Especially with penicillins, right?
Penicillins and sulfa drugs are common culprits, but it can happen with any. And specifically for older adults receiving antibiotics, if they develop diarrhea, a common side effect teach them to really push fluids. Monitor them closely for subtle signs of dehydration, like new confusion, low blood pressure, or that fast heart rate.
Okay, so that's treating the infection itself. What about managing the fever symptom? We use antipyretics like acetaminophen.
Yes, drugs like acetaminophen, Tylenol, or sometimes NSAIDs are used to reduce fever. This is mainly for patient comfort, or the fever poses a specific risk like in patients with heart failure or those prone to febrile seizures.
But they're not always given.
Right. Sometimes providers prefer not to treat the fever aggressively, especially at first, because the fever pattern can actually provide clues about the illness and how the patient is responding to treatment. Masking it with antipyretics can obscure that picture.
So if we do give them, what should we watch for?
Well, when the fever breaks after giving an antipyretic, patients often have waves of sweating, and their blood pressure might drop a bit. So regular scheduling, rather than just PRN, might be better for stable control. And encourage fluids to replace what's lost through sweating.
What if drugs aren't enough or aren't used? What about external cooling?
Yeah, we can use methods like hypothermia blankets, placing ice packs in the axillae and groin area, or sometimes sponging with tepid, not cold water.
Is there a key safety point with external cooling?
Absolutely. The most critical thing is to monitor for and prevent shivering. You need to teach any assistive personnel helping with this to report shivering immediately. Shivering actually increases metabolic rate and heat production, the exact opposite of what you want, and means you're cooling the patient too quickly.
Good point. And one logistical note about cooling methods.
Right. Using fans is generally discouraged in patient rooms. They can blow pathogens around the room, and, importantly, they can disrupt the airflow in negative pressure isolation rooms, potentially compromising their effectiveness.
Wow, okay. This deep dive has really covered the core concepts. Just to recap for everyone listening, key takeaways include understanding that chain of infection, especially the susceptible host, knowing the difference between standard precautions and the specifics of airborne, droplet, and contact precautions.
And recognizing the danger of MDROs and C. diff, plus those specific management strategies like using sporicidal cleaners or understanding biofilms.
Definitely. And looking ahead, the fight against these infections, especially AMR, is evolving. We're seeing exciting research into things like phage therapy using viruses that specifically target bacteria and work towards universal vaccines, like a broader influenza vaccine currently in trials, which could really reduce the burden of infectious diseases. That brings us to a final thought for you, our listener. Considering how interconnected our world is through global travel and the ever-present, if thankfully rare, threat of bioterrorism, how do we need to adapt these core infection control principles? How do we stay prepared for pathogens that might seem distant today, but could be, quite literally, just a plane ride away tomorrow?
Something to think about. Thank you for joining us for this deep dive.
And a warm thank you from the Deep Dive team. We'll catch you on the next one.